Hello, welcome to Concise Approaches on Internal Medicine. My name is Carolina Hoyos, and I'm going to present blood glucose monitoring in the ambulatory management of non-pregnant adults with diabetes mellitus. For the introduction, as we know, all people with diabetes mellitus who use insulin and some people who take other glucose-lowering medication that can cause hypoglycemia should monitor their glucose concentration to help maintain safe target-driven glucose management. In this presentation, I'm going to talk about DMT1 and DMT2. Then I'm going to talk about blood glucose monitoring systems, and finally I'm going to talk about how to use glucose information that is obtained, especially in patients with basal insulin. So, for people with type 1 diabetes, monitoring of glucose is widely accepted as beneficial. Frequent testing of glucose levels is necessary to achieve A1C targets safely without frequent or severe hypoglycemia. And this patient may use blood glucose monitoring with finger sticks and glucose meter, or they can use continuous glucose monitoring. It is generally used in people with type 1 diabetes if it is available or affordable. If the patient uses finger sticks, testing at home should be done at least 4 times daily before meals and at bedtime, occasionally postprandially prior to exercise, and occasionally for safety at 3 a.m. It is important that the frequency of testing may vary based on individual needs. In type 2 diabetes, blood glucose monitoring is encouraged for people who take insulin since insulin can cause hypoglycemia, and dosing may need to be adjusted based on ambient glucose levels. Also, glucose monitoring similarly may be helpful in adults taking sulfonylurea, which also can cause hypoglycemia. About the frequency, it depends on the glycemic target set and the treatment used. The frequency of testing may be vary based on individual needs. We have two regimens. The first one is basal and prandial insulin, and the second one is basal insulin. So, in the first one, the optimum frequency of BGM is similar to that used in type 1 diabetics, at least 4 times daily before meals and at bedtime, and in the second one at least once daily, preferably fasting, and sometimes before dinner or bedtime. It is important to mention that additional checking, for example 2 to 3 hours after eating or at bedtime, can be useful to direct change in therapy. About the systems, many current glucose meters are reasonably accurate and require a very small drop of blood, and it is very important about the strip that leaving the lid off for periods of time with exposure to heat, moisture, and humidity can cause erroneous glucose value readings. About the site of testing, we have the fingers, outer upper thigh, at least 4 centimeters from the navel, and posterior region of the upper arms. Also, we have potential mistakes. Errors in BGM are most frequently attributed to operator error, and other problems arise from failure to use test strips not appropriate to the meters, or not calibrate the meter, or use dairy meters, or poor skin preparation. And finally, we have to educate the patient. So, if you are on a basal insulin schedule, you should perform fasting blood glucose checks every day with glucose targets in mind. So the lower limit is 80 and the upper is 130. So if you don't reach the goals, make the following adjustment with the following indication. It's very easy. First, if fasting glucose is less than 80, decrease 1 or 2 units of basal insulin and continue with adjustment until goals are achieved. If fasting glucose is more than 130, increase 1 or 2 units of basal insulin And if fasting blood glucose is in the range of 80 and 130, proceed to leave the same dose of insulin. And that's all. Thank you for watching.